Hi, Mike Gibson, Steve Nissen, coming to you live from the ADA meeting. Steve, you just made a great late-breaking presentation. You know, the CLEAR Outcomes study looked at bempedoic acid in statin-intolerant patients, but today you presented outcomes in the primary prevention population. Very important group. Talk to us about what you found.
Well, first of all, it's important to recognize that less than half of patients at high risk, primary prevention patients, are actually receiving cholesterol-lowering medications in the United States now. And this has been a problem for many years. Most of the recent trials, for example, the PCSK9 inhibitor trials, studied only secondary prevention patients. In fact, in some cases, patients after an acute coronary syndrome. We included 4,200 patients in the primary prevention subgroup within the CLEAR Outcomes trial. Out of 13,970 patients, 4,200 were primary prevention. The results in that subgroup were simply stunning. The hazard ratio for four-component MACE, death, stroke, MI, or coronary revascularization was 0.7, a 30% reduction. For cardiovascular death, the hazard ratio was 0.61, a 39% reduction. And for myocardial infarction, a statistically significant 39% reduction. The number needed to treat was about 43, while the absolute event rates were indeed lower in this population. The treatment effect was much larger. And we should recognize that this is not the first time we've seen this. It's just been a long time since anyone has done a cholesterol-lowering study in patients that are primary prevention. That wasn't what was done with Improve It or any of the other recent trials. You have to really go back to Jupiter in 2008 to see what might be called a true primary prevention population. That study was stopped early with a very large reduction in major events. We were really quite surprised by the mortality findings. By the way, not only was cardiovascular death reduced in a statistically significant fashion, but so was all-cause mortality. Wow. The hazard ratio for all-cause mortality was 0.73, a 27% reduction. We see this as a wake-up call to our colleagues that if we're not treating patients in the primary prevention subgroup with high cholesterol, and we're missing a great opportunity to reduce morbidity and mortality. And remember, we were using a drug with relatively modest LDL lowering effects. It's assumed that the same effect would be likely observed with statins. Now, there is one other nuance. We did get very good reduction, not only in LDL cholesterol, but in hsCRP. And the question here is, did we see this big effect because of having a drug that produces both cholesterol lowering and anti-inflammatory effects? And that is really, at this point, just speculation.
Steve, was there a positive interaction term? I mean, was the magnitude of benefit different in the primary prevention compared to the secondary prevention?
Yes, there was. It's in the it's the original New England Journal manuscript. We did not play that up. We thought that the primary manuscript should, in fact, report on the totality of the findings, and we're careful about not emphasizing subgroups in the main manuscript. But we saw that there was an interaction term, and that's what led us to explore separately this modest size group of primary prevention patients. But 4,200 patients is not small, and the significance of these effects was really quite substantial. The p-value for four-component MACE was 0.002 in primary prevention, and the p-value for three-component MACE was less than 0.001. So death, stroke, MI, a p-value of less than 0.001. We think it's very unlikely that's a chance occurrence. We really do think that these patients in the primary prevention group that are at high risk, particularly if they have diabetes, they need to have cholesterol lowering drugs to see this kind of rather profound benefit.
Steve, in recent years, we had seen a decline in cardiovascular mortality. Now it's starting to come back up again. Some of us hypothesize that some of this may be due to not having targets anymore. What do you think? I mean,
Yeah.
this is a wake-up call. I mean, do we need to be more aggressive? Do we need to get back to targets? What are your thoughts?
Well, I've never been in favor of abandoning targets. And I, caused some controversy by being very critical when the guidelines originally in 2013 took away targets. I still use targets. I still get high-risk patients to low LDL levels. These patients started out at about 140 milligrams per deciliter. Their LDL was lowered by 30 milligrams per deciliter. So, moderately lower, but not to levels of 70, which some people would advocate. But we are missing the boat. Now, I personally have believed that this uptick in cardiovascular event rates relates to the obesity epidemic. And notably, the body mass index in our patients was relatively high. Let me just look at that. So it should be in here somewhere. Yeah, BMI was 30. It wasn't severely obese, but it was in the obese category. So that's certainly a factor. Now, one more thing. I know you are aware of the fact that there's been some pushback on using cholesterol-lowering medicines in primary prevention, particularly in women. And the 59% of these patients were female. So here's a group, largely more than half of whom were women, who had these very large reductions in morbidity mortality. And so I know you're quite aware of who the disadvocates have been about the treatment of women. They're wrong. Women with risk factors, high cholesterol, need to be treated.
So, Steve, who's the optimal ideal patient for bempedoic acid in primary prevention?
Well, first of all, our message here is more about lipid lowering in primary prevention. But in this case, I think patients with diabetes, patients with other risk factors and high cholesterol are appropriate for treatment with cholesterol-lowering drugs, one of which is bempedoic acid. But they may also be candidates, if they can tolerate them, for statins. I do think this is about the cholesterol lowering and CRP lowering effects, more so than the specific drug that was used. But that can be debated.
Yeah, I mean, we heard from Dr. Linkhoff from the endocrine meeting that, on a milligram per milligram basis, the event reduction was similar between bempedoic acid and a statin. So it's independent of the statin mechanism, at least for bempedoic acid, that you seem to get this benefit. Now, it wasn't true, of course, with the trial you and I did together with an agent that didn't work out that way, but it does seem to be lower is better. Steve,
Yeah.
thanks so much for joining us.